So the first case, as you can see, is MSM, 24 years old. He has a viral load of 187,000 copies with 448 cells. The baseline genotypes failed to detect any mutation. He has not HBV nor HCV. Creatinine clearance is okay, and liver enzymes are normal, and his HLA is negative. He has no significant past medical history. He's a frequent consumer of migraine relief pills. Occasionally, he admits to drink some alcohol and to use marijuana. He is sexually active with a steady HIV negative partner. He attended several clinical visits and is interested in starting HIV therapy. He prefers to take a few pills as possible, but wants what you think is best. So we don't have a voting system, but you can just raise your hands and about the options that I will show you. What would be your choice for the third drug? Would it be efavirenz? Would it be rilpivirine? Would it be a boosted PI? Would it be elvitegravir with cobicistat? Would it be dolutegravir, or would it be raltegravir? So who would go for efavirenz in your clinical practice? We have a couple of hands there. Who would go for rilpivirine? I see no hands. Boosted PI? Seems not to be so popular. Elvitegravir cobicistat? One hand over there. Dolutegravir? I see more hands. And raltegravir? Okay, I have a couple of them. Okay, so let's see what some opinions, and I give you mine, which doesn't mean that this is the right one. We have many options for initial therapy. As I said early this morning and during the discussion, if a patient doesn't have baseline resistance and he or she is adherent, with almost any powerful combination, you will get viral load undetectable. Most patients opt for a single tablet regimen over a multi-tablet regimen given the choice, but this is not necessarily true in all settings. We have seen patients that, for instance, in the US, it seems that the single tablet regimen is a very important one, while in Europe and in other regions like Latin America, patients can take either one or two or three pills as long as it is well tolerated. So a variety of single tablet regimens would be appropriate choices for this patient, or eventually with 2 or 3 pills, based on the issue that he is young and healthy and has no comorbidities. So some considerations about your options. Efavirenz has been used for a long time. We have extensive clinical experience with this agent, but as you know, CNS adverse events preclude the use of this drug in about 15% of the patients who cannot tolerate this drug. And it's very important for developing countries that if we don't have a baseline genotype, you have to take in account that non-nucleoside resistance is increasing. For instance, in my country, which still Atripla is the most frequently prescribed regimen in Argentina, we are seeing between 10 and 15% resistance in naive patients. So our advice to the national AIDS program is to include baseline genotypic resistance if you want to keep using Atripla as the main regimen. Rilpivirine will be contraindicated in this particular case because it doesn't work that good in patients with more than 100,000 copies. Elvitegravir and boosted PIs. Be reminded that this patient is a consumer of migraine killer medicines, and the use with cobicistat or with ritonavir could drive to a very severe reaction like ergotism, and we have seen cases of that with ritonavir. Be reminded that cobicistat is as strong as ritonavir in inhibiting the CYP453A enzyme, and any medication that is metabolized in this enzymatic system will get very high levels, and in some cases it might be very risky. Dolutegravir could be a very good option. We have different studies that shows that in first line it works, and raltegravir is also a popular choice, and as Mario pointed out, it has been used for the last 8 years with a very good safety profile. So any of those integrase inhibitors could be a good option for this particular case. So let's make it a little bit more complicated. Now it's a woman with an HIV RNA of 87,000 who is considering pregnancy in the near future. I remind you that the CD4 count is 448 cells. The viral load in this case is 87,000, but she is a woman and she wants to get pregnant. So, again, raise your hands if you would prescribe efavirenz in your clinical practice. We have a couple of hands. What about rilpivirine? I don't see any fans. Boosted PI. Nobody would prescribe a boosted one. Only one hand. I mean, I'm not asking you for the sophisticated, best scientific answer. I want to learn about your clinical practice. Nobody is using boosted PIs in pregnant women. Okay. Good enough. What about elvitegravir covicistat? I don't see any. Dolutegravir? I see one hand. Raltegravir? I see a couple of hands. Okay. So let's see what we have. Most data in pregnancies concern boosted PIs. As you know, Calitra has been used for a long time in pregnant women. And in the last couple of years, atazanavir ritonavir has also been approved as a potential drug. As you know, boosted PIs have severe issues in terms of GI intolerance. In my clinical practice, we don't use atazanavir ritonavir in pregnant women because we are very concerned regarding the jaundice issue, which in the third trimester is always confusing because you may have really a disease linked to the liver function, which can be confusing with the jaundice that you get with atazanavir. Most data that we have are based on the background of CDV3TC, but increasingly tenofovir FTC has been used in pregnant women, and it doesn't seem to be that toxic as we thought in the first years. Some care providers would not use efavirenz based on the old data we saw that there might be some kind of toxicity, in particular regarding the neural tube formation. These data have been seen in animals, but in humans they are not being confirmed. And some guidelines, including the WHO guidelines, keep efavirenz as an option for first-line treatment in pregnant women. Eventually, other guidelines also do so. In practice, what is happening is that many pregnant women, they come to the clinic while on antiretroviral therapy, taking efavirenz, and in this particular case, the stopping efavirenz is not a recommendation because almost the first trimester is already gone, so it wouldn't make much sense. So regarding rilpivirine, there is no evidence of teratogenicity in rabbits or in other animals, but there are not enough data to use rilpivirine in pregnant women. Boosted PI are part of the recommendation in pregnant women in most guidelines, with the limitations that we are talking about regarding tolerability. Elvitegravir covicistat has no data in pregnant women. Raltegravir is now recommended as first-line drug for pregnant women in the DHHS guidelines, and dolutegravir is listed as a potential alternative. There are not enough data. They are being collected now during the ARIA study. The ARIA study that will be presented later this week next week indeed, in this conference. Is a study that has been done with dolutegravir exclusively in female patients, and if eventually a participant in that study would become pregnant, they would be kept in the study in a separate study, trying to establish if there is any consequence either for the pregnancy process or for the newborn. So we will see what happens. So I don't know how are you doing with time. Okay, so let's go quickly to another case, a completely different one. This is a 28 years old, infected MSM, previously refused to take ART, and now has been referred to you. He has an HIV RNA of 78,000 copies, a CD4 cell count of 70. As you can see, he has a wild-type genotype. He is co-infected with HBV with a high viral load. He's HCV negative. His creatinine clearance is okay, is almost affected. CBC is normal, and he has Kaposi sarcoma. He binges on alcohol but denies other drug use, and he will try ART if you recommend it, and I assume you would recommend it. What would be your choice for the third drug in this case? Would it be efavirenz? Let me see. We have some hands. Again, I'm asking you about your clinical practice, not about the politically correct answer. So, rilpivirine, nobody. Boosted PI. I'm surprised nobody is using boosted PI in this room, which is kind of strange. Dolutegravir, you get your lunch anyway, so don't be pushed. Dolutegravir, raltegravir, a couple of hands we see there. Okay. So non-adherence is a concern in these patients. So the issue of using a boosted PI in this particular case has pluses and minuses. A plus would be that the high resistant barrier would be good in terms of a patient that you're not sure that he would be adherent or not. On the other side, the pill burden and the issue of tolerability could work against this particular case. And since this is a ritonavir boosted PI, again the issue of drug-drug interaction in a patient that might need some chemotherapy for Kaposi sarcoma could be a problem. Rilpivirine-based therapy is not recommended in this case because the patient has a low CD4 count. So be reminded that rilpivirine, you can use it as long as your patient has not a very advanced disease. Raltegravir-based therapy may be a good choice for co-administration with chemotherapy due to the lack of drug-drug interactions, and the same holds true for dolutegravir. And it has a convenient dosing that is only once a day, and the resistant barrier is adequate, so you could use again any of those two integrase inhibitors. And that's it.